Good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this discussion on Adverse Childhood Experiences, or ACEs. Next slide. Our nation's children are under stress. Every year, roughly 3 million children in the US are exposed to shootings. More than 200,000 American children have lost a parent or primary caregiver due to COVID-19. And millions of children have been exposed to economic hardships during the pandemic, such as food insecurity and homelessness, with a disproportionate impact on Latino and Black communities. These stressors are all in addition to the ACEs that most children experience at least once in their lifetime, such as neglect and abuse. We know ACEs can have lasting negative effects on health. 5 of the 10 leading causes of death are associated with ACEs. Next slide. Today, we will hear from a prestigious panel of experts to learn more about actionable strategies to prevent ACEs and programs to support children and break the cycle of adversity. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers, along with today's agenda and copies of their slides on our website. We also invite you to join our conversation on Twitter using the hashtag #HealthyChildrenBrightFuture. Next slide. I am now pleased to introduce our first speaker, Dr. Phyllis Nylon, the Senior Scientist for Preventing Adverse Childhood Experiences in the Office of the Director of Division of Violence Prevention, National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. In this role, she coordinates their work relating to the prevention of ACEs and collaborates with both internal and external partners on advancing the field of ACEs prevention and response. We're so honored to have her with us today to share CDC's commitment to preventing ACEs. Go ahead.
Thanks so much, Catherine. And thank you all for having me here today. I'm going to start us off by just giving a little bit of background on ACEs, and then talking about work that we're doing at CDC to support the prevention of ACEs. Next slide, please. Next slide, please. Thanks. Adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood, so from birth to age 17, including witnessing or experiencing violence, experiencing neglect, but also included are aspects of the child's environment that undermine their sense of safety, stability, and bonding, such as growing up in a household with substance abuse problems, mental health problems, or parental separation or incarceration. And on the left-hand side of the screen, you'll see the traditional ACEs that were measured in the original CDC Kaiser ACEs study conducted in the 1990s. But at CDC and in the field of ACEs, there's a great recognition that these really didn't capture the full range of traumatic events that can happen to children in childhood. So on the right-hand side, you'll see what we're kind of calling expanded ACEs, or additional ACEs that weren't originally measured, but certainly have the potential to be traumatic and cause toxic stress. Next slide, please. So ACEs and their associated social determinants of health, things like living in under-resourced or racially segregated neighborhoods, frequently moving, and experiencing food insecurity, all of these things can cause toxic stress, which really is an extended or prolonged activation of the stress response system. Some children may face further exposure to toxic stress from historical and ongoing traumas due to systemic racism or the impacts of multi-generational poverty, resulting from limited educational and economic opportunities. And we know now from this study on toxic stress and the biological impacts that it has on children, that the impacts are wide-ranging, from disrupted neurodevelopment and changes in the brain that can have direct results on disease, disability, and social problems. But also those neurodevelopmental changes from experiencing toxic stress can affect things like attention, decision-making, learning and response to stress, to increase risk of becoming involved in crime and violence, using alcohol and other drugs, and engaging in other health risk behaviors. And all of these can have significant impacts on life potential, susceptibility to disease, illness, and mental health challenges over the lifespan and early death. And the effects don't stop there. They can be passed on to the next generation. This slide really just demonstrates the number of different physical, mental, and behavioral health outcomes that have been related to ACEs. And we know that there is a dose-response relationship between ACEs and all of these outcomes. So the more ACEs a person reports having experienced in childhood, the higher likelihood it is that they will develop one of these health or opportunity problems. Next slide, please. Oh, sorry, I've got behind on saying next slide, so I'm going to ask you to skip forward. So this is the slide that that really demonstrates kind of all the different health, physical health, mental health, and behavioral health outcomes that that ACEs have, and the dose-response relationship that ACEs has. I'm sorry, I got ahead of you. So the next slide. Now I'll talk some about our surveillance efforts at CDC that help us understand the prevalence of ACEs. Next slide. So the first and kind of most comprehensive way that we measure ACEs currently is through the Behavioral Risk Factor Surveillance System, or BRFSS. And this is an annual cross-sectional telephone survey of health-related risk behaviors, chronic health conditions, and use of preventative services among adult United States residents. And there is a CDC-sponsored ACEs module, which states can use to measure ACEs and their relationship between ACEs and all these other health outcomes. Next slide, please. So as of 2020, all 50 states and DC have collected ACEs data at least once from adults since 2009. So we do have a paper hopefully coming out later this year that will give us an idea of the ACEs burden across all 50 states and DC. Next slide, please. This is our vital signs on ACEs that came out in 2019 that was based on BRFSS data. This was based on data from 25 states that had used the ACEs module between 2015 and 2017 to estimate long-term health and social outcomes in adults that contribute to leading cause of illness and death and reduced access to life opportunities. We know from the BRFSS that ACEs are common. 62% of adults report at least one ACE, and as you can see from the top of that vital signs snapshot, that roughly 1 in 6, or 16%, report having experienced 4 or more ACEs in childhood. And as I said, we know that the accumulation of ACEs is linked to much higher risk of all of these outcomes. Next slide, please. So this study that the vital signs was based on found that preventing ACEs has the potential to reduce leading causes of death, such as heart disease, cancer, respiratory disease, and diabetes, and also can have that preventing ACEs can also have a positive impact on education and employment levels. Next slide, please. But measuring ACEs among adults doesn't give us a good sense of what the burden or prevalence of ACEs is now, or any ability to monitor trends or changes over time, especially if we are implementing prevention strategies in states. And if we want to understand the current burden of ACEs prevalence or monitor trends, we need to get a snapshot of ACEs from people who are still in childhood, which is where the Youth Risk Behavior Surveillance System comes in. The YRBSS is run out of CDC's Division of Adolescent and School Health. There's a national YRBS that produces national estimates of health risk behaviors. And then also there are state and local jurisdictions who administer the YRBS. And all but 4 states in the US administer the YRBS, and many large school districts and several tribal nations also administer their own YRBS. Next slide, please. In FY20, CDC got its first ever appropriation for ACEs. With this money, and part of this money, we incentivized local administrators of the YRBS to add either 8 core ACEs questions, so those really map onto those original ACEs questions on my first slide that were in the original study, or 16 core and expanded questions to their local YRBS. In 2021, 21 state and local jurisdictions added either 8 or 16 CDC-developed ACE and Positive Childhood Experience, or PCE, questions to their YRBS surveys for the first time. And we look forward to seeing that data and starting to analyze it here very soon. Next slide, please. This just captures sort of what is in those 2 tiers of questions. So again, those who did the 8 questions, they map pretty closely onto those 8 traditional questions. We didn't ask about parental separation or divorce, and emotional and physical neglect were combined into 1 neglect question. For tier 2, the ones who added 16 questions, they added those 8 questions on ACEs, and then 2 past year incidence questions on emotional and physical abuse. 3 of what we're calling community ACE questions. Those are some of those expanded ACEs that were on the right-hand side of that original slide. These questions ask about witnessing community violence, experiencing discrimination based on race or ethnicity, and experiencing discrimination based on gender or sexual identity. And then finally, 3 positive childhood experiences questions as well. Next slide, please. I don't have time to go into any of these in depth, but certainly can answer questions about them. We have worked with the National Survey of Family Growth and the National Health Interview Survey to add some ACEs questions to their survey. The National Health Interview Survey is doing a pilot with adolescents, and so that enables us to look at the concordance between adolescent reports of their own ACEs and parent reports of those adolescents' ACEs. So that's going to be exciting when we get that data in. And then we've also been working with the National Survey of Children's Health, which already collects a lot of kind of those household challenge ACEs, but we are working with them to see if we can add questions on experiencing violence. Next slide, please. So preventing, sorry, I'm having some technical difficulties. Preventing ACEs is a CDC priority. Our goal is to sustain and create and sustain safe, stable, nurturing relationships and environments for all children and families, and to help children reach their full health and life potential. And it is a priority for one of the 3 stated priorities for the National Center for Injury Prevention and Control, where I sit. Next slide, please. So CDC has produced a suite of technical packages to help states and communities take advantage of the best available evidence to prevent violence, including the many types of violence and social, economic, and other exposures in the home and community that adversely affect children. The first 5 on the left-hand side of the screen are the original technical packages, and then we went through all of those and created a Preventing Adverse Childhood Experiences resource tool based on all the strategies that are evidence-based to prevent ACEs as well. Next slide, please. This is a quick snapshot of the strategies to prevent ACEs, which I'm going to quickly run through now. Next slide, please. Strengthening economic supports for families is a multi-generation strategy that addresses the needs of parents and children so that both can succeed and achieve lifelong health and well-being. The two approaches under this strategy are strengthening household and financial security and family-friendly work policies. Next slide, please. Changing social norms that accept or allow indifference to violence and adversity is really important in the prevention of ACEs. Approaches under this strategy include public education campaigns, legislative approaches to reduce harsh physical punishment, bystander approaches, and efforts to mobilize men and boys as allies in prevention. Next slide. The next strategy focuses on ensuring a strong start for children and paving the way for them to reach their full life potential. Approaches under this strategy include early childhood home visitation, high-quality childcare, and preschool enrichment programs with family engagement. And all of these strategies can both have evidence base for both preventing ACEs and for mitigating the consequences of ACEs. Next slide, please. Teaching skills to help parents and youth handle stress, manage emotions, foster healthy relationships, and tackle everyday challenges of life is an important part of a comprehensive approach to prevent ACEs. Approaches under this strategy include social emotional learning programs, safe dating and healthy relationship skill programs for young people, and parenting skills and family relationship approaches. Next slide, please. The next strategy is about connecting youth to caring adults and productive after-school activities. These connections are important for both preventing ACEs and for buffering against the impact of ACEs among youth who have already experienced them. And approaches under this strategy include mentoring programs like Big Brothers, Big Sisters, and after-school programs. Next slide, please. This last strategy focuses on timely access to intervention and effective care, support, and treatment for children and families in which ACEs have already occurred to help mitigate the health and behavioral consequences of ACEs, strengthen children's resilience, and break the cycle of adversity. Approaches under this strategy include enhanced primary care in which children and families are connected with referrals and resources by their healthcare providers, victim-centered services for children and adult survivors of intimate partner violence, including shelter, housing support, crisis intervention, legal intervention, and other resources. Also, treatment to lessen the harms of violence exposures for children. And then also treatment to prevent problem behavior and reduce risk for later violence among adolescents who are demonstrating risky behaviors already. And then the last approach under this strategy is family-centered substance use treatment programs. These are programs which simultaneously treat their parental substance use problems while addressing the needs of their children with this ACEs exposure. Next slide, please. So this is a slide on our Preventing Adverse Childhood Experiences Data to Action programmatic effort. As I said, in FY20, we got our first appropriation for ACEs, and this was funded after that. Out of that appropriation, these grantees are entering their third year, and they are tasked with building and enhancing an ACEs surveillance infrastructure. So some way to collect ACEs data within their state. To implement ACEs prevention strategies, so choosing a primary prevention strategy among the strategies that I just went through, and then conducting foundational activities to really support a data to action framework. So using the data that they collect in Goal 1 to inform and hone their prevention strategies among Goal 2. I also wanted to mention programmatically, we can go to the next slide, our Essentials for Childhood programmatic endeavor. These grantees are tasked with the goals that are here on this slide, and they use the strategies that are captured in the Preventing Child Abuse and Neglect technical package, which are very, very similar to the strategies that I just went through that are in the Preventing ACEs package. So these are two ways that CDC is providing support to states in order to try to really get these evidence-based strategies out into the community and support prevention of ACEs. I know I'm over time. Before I wrap up, I also just wanted to point out and this is the next slide, that our Veto Violence website has 5 different trainings for adverse childhood experiences. The first one that you see at the top is an overview and public health approach to ACEs. It's for people of all professions and education levels and audiences. And then each of the 4 on the bottom are profession-specific ACEs trainings. So the ones for mental health providers and pediatric care providers, the 2 in the middle, have been on our website for several years. We're really excited about the bottom left is the training for educators. That was just released in July and is out in time for the new school year. And then coming this fall is a profession-specific ACEs training for faith leaders. And I'm sorry for going over time. I will stop there. On the next slide, it's just my final slide. And I'll turn it back over to Catherine now.
Thank you so much for your leadership and CDC's leadership on preventing ACEs. Our next speaker is Dr. David Osher, Vice President and Institute Fellow at the American Institutes for Research. His work focuses on school climate and the conditions for learning and social emotional learning. We're so grateful to have David on our panel today to share his research on creating safe, supportive learning environments.
Okay. Thank you very, very much, Catherine, and also thank you very, very much, Phyllis, as well. I think you really set the stage very, very well for what we're talking about, and the CDC has and continues to do extraordinarily important work in this area. Next slide, please. My work with others over the past half decade has really focused on the ongoing interactions between what's happening within individuals and between individuals in environments, and how that both contributes to both thriving on the one hand, including well-being, and on the other hand, how it also contributes to ill-being. And the framing I'm going to give here comes from that. There are resources on the second page of the resources about the science of learning development and the syntheses that we've done that will provide the scientific basis for this work that is not just done by me, but with a whole set of other people as well. I think the key here is that individuals can thrive or languish across dynamically interdependent individual and collective ecosystems. And thriving and well-being are not just individual, they're collective. They're not just objectively things that we can measure, they're also subjective. They're not just in any one domain, they occur across all life domains, and those domains coact. And they're in all parts of every child's and every adult's life spaces. And in those spaces, the experiences people have, the relationships they have between and among each other and environments shape how adults and children interact and develop. And this also shapes what we know about what contributes to resilience or ill-being. When a parent or a teacher is under stress, they're less likely to be able to support a child who's under stress or who's experienced trauma than the opposite. And it's very important to understand that when we think about intervention, because the child is an important target, but she or he is not the only target. And what also affects things is both among children and adults, the interrelated cognitive, emotional, and cognitive capacities that people have and affect themselves. And cognitive capacity, for example, is not your basic intelligence level. It's your bandwidth. Can you do something or can you not do something? When you're working 3 jobs, it's much harder. When you're having more kids than you can handle, it's much harder. These capacities are affected by the conditions around people. We can help adults, we can help young people succeed and thrive and be resilient, or the opposite, or they can be undermined. And relationships, as I said, between people, the process of meaning making that they make individually and collectively, the effects of stress drive growth and development, which can be a good thing or a bad thing. When it's toxic stress, it's going to be a bad thing. And the historical context matters. The issues of the expanded ACEs always existed. It's just the fact that the initial Kaiser Permanente database tended to be very, very middle class and didn't pick up what we know has existed. We now know it, and it's very, very real. And the current social conflicts as well heighten these issues. Next slide, please. You may want to look at this document. There's a lead afterwards, but I'm here. It's here because of the fact that I want you to think about just this model for a second. And it's that dynamism is important. And while this talks about how we can build success, think about reversing it. It's also how we can create ill being and a cascade of negative coactions and interactions and outcomes. Next slide, please. We now know, and the science of learning, development, syntheses that I and others have done really further establish it, that ACEs are not destiny. You know, when I adopted my children and who had experienced a bunch of ACEs, the people I was working with really tried to say to me, at best, what you could do is prosthetics. This is 30 years ago. We now know that we can do a lot better than prosthetics. We now know a great deal about the promise of neuroplasticity. And what we also know, and I know from other work that I do and other people do, about the profound human capacity to learn. Now, we also know there's a profound capacity to learn good things. There's also a profound capacity to learn silly things. But the brain can heal and grow. People can learn and change. Resilience, personal growth, and even thriving are possible for everybody. But we have to create the safe and supportive environments to enable it to happen. We have to create, adapt, and support adaptable, caring relationships between adults and peers, siblings. We have to build around young people and adults ecological assets. And when we do this, we can create those three components of thriving that you can read about if you look at that report. The floor of thriving, which is incredibly important, is well-being. But thriving also includes a sense of groundedness, knowing where you are in time and place, feeling that you're connected to other people, and a sense of individual and collective agency, that I can do something about it. You all know the word S and then blank happens. Agency is about the fact that that might be happening, but I can do something about it, and we can do something about it. And that becomes really important when we think later on about trauma-related interventions. Next slide, please. Catherine laid it out, you know, in terms of the variety of ACEs. I just want to point out again that these things really will connect very deeply in all sorts of different ways. You can look at the slide at some other point. Next slide, please. And we can think about the conditions that perpetuate adversity and trauma. And remember that downward dynamic that I suggested as well. Trauma, toxic stress, complex stress, multiple and cascading traumas. Not just an individuals, but connection between them. You know, a traditional ACE is having a parent who's been arrested. Think about that ACE within the context of historical racism and institutionalized racism, and the experience of Black people with mass incarceration, and understanding when a policeman comes in and arrests a Black person more than a white person, that's not just an ACE coming out, it's multiple different things that can co-act. There's also the possibility institutions do them all the time of re-traumatization. There's negative learning. People always learn. And there's the amplification of ill being. And this happens, you know, by reversing all the good things I talked about before, by creating threatening and unsupportive environments, by using harmful interventions and building ecological risks, and using harsh, punitive, uncaring, unsupportive approaches when we interact with other people. I think Catherine really talked about the extent to which ACEs really affect young people in the short and long run. I'll just say that in addition, it affects issues of hope. It can affect your sense of connection and efficacy in the world. Next slide. This comes from my colleagues at the Center for the Developing Child, who are part of the Science of Learning and Development Alliance, and it really just reflects some of the things that Catherine talked about. I will not elaborate now, so we can go to the next slide. And this slide also reflects the fact that we don't want to just be thinking about the individual, even though the individual is key. We have to think about those relationships, and we have to think about how those are nested in communities and workplaces, including the inter-coaction between those different parts of a person's ecology, and then the effects of large social policy. And we have seen all of those play out in the last 2 years in terms of COVID, in terms of the racial conflict and so forth, and how it occurs within segregated communities and how it's experienced differently with different levels of adversity. Next slide, please. The key message here, besides focusing on adults as well as on young people, is that support is the key facilitator of healing, of growth, and of change. And for that to happen, adults as well as peers and siblings need the support so that they can attune to each other and to a troubling child or a troubled child, to provide emotional support and buffer stress, to be culturally humble and competent and responsive and learn from others and listen and be empathic, to support people's social, cognitive, and emotional development, to provide both instrumental support, but also provide the relational support that is even as key, if not more key. And as I said before, stress, fear, and cognitive overload and a lack of empathy undermine the ability to provide support. We know that teachers or policemen who actually may know about implicit bias are less likely to be able to handle that when they're under stress and under high levels of bandwidth challenge. And then they go back to a default system that involves implicit biases and the traditional tools that they learn to handle. Next slide, please. Why should schools and other service settings address trauma? Because they won't realize their goals unless they're able to. And I won't talk about it here, but I think there really is a reason, not just in terms of the needs of young people and families, but also in the needs of the institutions to really collaborate and coordinate and create a trauma-sensitive, trauma-informed system. Next slide, please. And what I want to say to you is that we both want to create trauma-sensitive places that include the ability to provide trauma-informed, more intensive interventions. And we also want to make sure that those approaches are equity-centered and centered on healing and centered on creating the conditions in the long run and not just the short run where people are more able to thrive and more able to prevent the causes of ill-being. And if you look at some of the references on the right side, and I particularly would refer you to the really important work by Sean Ginwright, who's at the University of California, San Francisco, on his approach to dealing with community trauma, which I think is extraordinarily important and suggestive. Next slide, please. I talked about trauma sensitivity and trauma informed. And this is for schools as an example, because I do a lot of work in schools, but I also do, and my colleagues doing a lot of work in other agencies. And just to know that what we need to be doing is to really not just focus on those people who we know have been traumatized. We can't ignore that in any way. We also have to know that both the people who we may not have seen or screened for trauma may actually have experienced it, but also they do things or don't do things that will affect other people in the environment. Next slide, please. Let me just talk for a second about the difference between a traditional environment and a trauma-sensitive environment. On the one hand, traditional environments, which are much less aware of the implications of trauma and how it affects behavior of children and adults, tend to be judgmental rather than trying to figure out what's going on for the young person and what can we do. The focus is on fixing individuals rather than creating a supportive environment that can help individuals heal and also prevent what's happening. A focus often in institutions and settings ends up being on management, on power, on obedience, and through control rather than power through collaboration, through people's ability to manage their own emotions. Traditional environments tend to be more reactive and punitive. Good trauma-sensitive environments are proactive and restorative. Traditional trauma environments are often siloed, and they see children that the exposure to trauma as being just isolated, whereas trauma-sensitive environments are much more integrated, and traditional environments tend to be more deficit-oriented. Trauma-sensitive environments more strength-based. Next slide. Let me just say that a key element is not just educating all staff on its effects and providing physically, emotionally, and identity-safe environments, but also eliminating the harmful iatrogenic things that are often done: corporal punishment, restraint, suspension, disproportionate surveillance, and harshness of responses, implicit and explicit bias, racial and cultural neutrality, school hardening policies that affect all children who have really experienced trauma and are dealing with it, but particularly minoritized and marginalized children. Next slide, please. And I'm going to now end it because I'm at my end. Just know that safety is not just physical, it's also emotional, psychological, and involves identity, among other things. Next slide. I've talked about this, so let's go to the next slide right now. And I just want you to know that what we really want is also not just to think about, I would suggest, trauma sensitivity, but really using transformative approaches that in the way in which we help people heal, we build individual and collective agency on the right. That's it's in blue. And that we do things that really build the way in which people can individually, collectively, both deal with things that have happened to them, but also prevent it from happening to them and others later on, which in its own right ends up being healing. And let me go to the next slide. And just to end this, I just want to say, and I'm just taking two very important chemicals that relate to our HPA system. One is oxytocin. As you know, it's something that really bonds us. The other is cortisol. It's one of the stress hormones. What we really want is to create in environments, whether it's in families or schools or agencies, whether it's among peers or adults, the flowing of oxytocin, which bounds but also is healing and actually helps people learn better. And we want to minimize the level of cortisol that really, when it's at a high level, is highly problematic. The following slides have a bunch of resources. I thank you very, very much. I'm happy to be available to you, and I pass it back to Catherine.
Thank you so much, David. And I'm excited to turn it over to our next set of speakers who will be sharing some on-the-ground efforts, incorporating some of the concepts we've been talking about today. And we'll hear first from the Blue Cross Blue Shield of Michigan Foundation, and I will turn it over to Myra to start.
Yes, thank you so much, Catherine. And since 1980, the Blue Cross Blue Shield of Michigan Foundation, we have been committed to providing financial resources for corporations, hospitals, universities, and community-based organizations to address health and healthcare needs. And included in that is adverse childhood experiences. And the state of Michigan, we rank 20th in the percentage of young people reporting 2 or more ACEs. And 6 of 10 of our young people have at least 1 ACE. Now, specifically for the state of Michigan, we found that 72% of young people with 4 or more ACEs reported feeling sad or hopeless, and that's compared to 17% of children with no ACEs. And then when we look at suicide risk, 46% of youth with 4 or more ACEs considered suicide. And then 21% of youth with 4 or more ACEs attempted suicide. And then in addition to that, we see risk behaviors. And so 63% of the young people with 4 or more ACEs reported not using a condom during intercourse. And that is compared to 39% with fewer than 4 ACEs. And if we can go to the next slide. So we have some amazing programs that are addressing ACEs on the ground. And since 2020, we have awarded 25 grants, one of which you heard of at a previous webinar, and that is the TRAILS, the Transforming Research into Action to Improve the Lives of Students. That was recently provided with a $50 million state appropriations from the state of Michigan to expand its program from the Detroit public school system and to bring that program statewide. Another program that we have is the Washtenaw Area Council for Children, and this is teaching young people at the age of 3 about body agency. And then in addition to that, we have a program with the Ruth Ellis Center, which is helping to assist LGBTQ+ young people that are experiencing housing insecurity. And today we have 2 amazing innovative programs that we're so glad are able to come and speak to you, because this is really such an important thing to show the on-the-ground approach. So we've heard a lot of the theoretical, and now it's time for us to hear about what's going on the ground. And so the first that I'll introduce is a community university partnership. And community university partnerships, they're so unique. They bring the combination of the research and then also the on-the-ground knowledge. And the second is a nationwide program, and this has been able to be replicated here in the state of Michigan. And previously it's been done in racial and ethnic diverse settings, and then also in rural, urban, and suburban communities. And first I will turn it over to El-Alamin and also Rodlescia Sneed. And Rodlescia is a professor at Wayne State University, and Leon is the founder and executive director of the Maid Institute.
Thank you, Myra. Good evening, ladies and gentlemen. My name is Leon El-Alamin, so happy to be here. I am the founder and executive director of the Maid Institute. And the Maid Institute is a community development reentry corporation that was established in 2015 to address issues that impact at-risk youth as well as returning citizens in different areas in which they have found themselves to be faced with many barriers due to environment, home life, and so forth. Next slide, please. The Maid Institute provides transitional housing, life skills, peer-to-peer mentoring and education, health and wellness, skilled trades, construction, training for returning citizens and at-risk youth. We also provide health and wellness and financial literacy. We use a holistic approach to recommend individuals who come through our program, at-risk youth or adults, back into the community who have been impacted by violence, mass incarceration, and other entities that distress them from being successful in the community. Next slide, please. Youth ages 16 to 24, predominantly African-American families, was our focus in this particular project. All youth participants are raised in low resource households. And part of our recruiting strategies was to focus on Flint's North Side, one of the most hardest hit areas in the city of Flint and Genesee County, that has also been impacted by the Flint water crisis and a slew of other things from violence and mass incarceration. I won't go too much into the statistics. I will let my colleague, Dr. Sneed, kind of address that aspect a little further. Next slide, please. Study racial. The lives of justice-involved individuals often characterized by poor social ties, discrimination, health problems, and food insecurities. Justice involved often turns to community reentry programs for support after reentry. Reentry programs mostly focus on employment and housing. Can we introduce supporter health and wellness programs into community reentry programs was our focus with this particular program. Next slide, please. Program structure. So resilient workshops is one of the things and tools that we utilize. Individuals, grouping them in small groups, addressing the mental health, first aid training, getting them exposed to those resources, connecting them with mentors and other community systems. The purpose of the project for us was to really engage the young folks ages mostly 16, 24 and so forth, that was and Flint, came from Flint's north side, to be really teach them how to be more resilient and to combat a lot of the social determinants that they're coming up against. Those who are unconnected to like educational institution, workforce, health and services and things of such, who have been impacted by large scales of violence and mass incarceration, was a main focus of the program. Through a multiple strategy, we were able to increase youth awareness of the impact that's repeated by exposure of trauma and violence and what that does to their health and overall well-being. Next slide, please. I'm gonna let my colleague kind of speak to more of the outcomes and go back more into the data, but I would like to add also that one way we were able to, again, as far as on the program implementation side, was utilizing the health and wellness program that we were able to create, which has like a nutritionist who teaches healthy dieting and eating habits and foods and things, in which has a great impact on how they think and how they behave, especially those who have been malnourished and come from these environments that's impacted by violence, mass incarceration, and things as such. Also, mentorship is a big part of the program. Gaining young folks' trust is critical before you can implement any kind of program. It's hard if you don't gain their trust. So we focus a lot on mentorship, exercising. These are little simple things that we found to be very effective when you're trying to curb impact of what we'll have the opportunity to see about what ACEs does to our young folks in these communities and so forth, and other traumas and things that can become barriers to their success.
Hi, everyone. I'm Dr. Sneed, and I'm working with Nylon and the Maid Institute to implement health and wellness programs, specifically among returning citizens that participate in Maid Institute programming. And a lot of the work that we're doing is really focused on developing and implementing a physical activity and nutrition program that caters to the specific needs of returning citizens. We are working in this program in partnership with Michigan State University Extension, which provides nutrition education. We also have a partner that does urban farming education as well. And a lot of what we're really focused on at this point is the feasibility and acceptability of implementing this kind of program among returning citizens. And so with that in mind, we have a few implementation outcomes. First, we're very much interested in reach. Are we able to successfully recruit and retain returning citizens in our programming that are representative of the broader population of returning citizens in the greater Flint area? Second, we're interested in fidelity. Are we able to deliver the program as intended? And if not, what types of modifications are necessary in order to effectively deliver the program that we've designed? And then finally, as an outcome, we're looking at satisfaction. Is the program acceptable to returning citizens? Is this a program that people are interested in continuing to participate in over time? And what can we do in order to improve the acceptability of the program? So these are just some of the outcomes that we're focused on in our partnership with the Maid Institute. Next slide.
Okay, thank you so much. And now we'll hear from Letitia Williams, who is a program director at Friends of Children Detroit.
Okay, thank you so much. Today I'm going to share the Friends of the Children 2-Gen approach, impacting generational change in communities across the states. How our work with our children affects ACEs, and all of the information that has come forward thus far in today's discussion. Next slide, please. Okay, no, we're good. Stay there. Nope, go back. Yes, thank you. We help to break generational cycle of poverty, enrolling children between the ages of 4 and 6 and mentoring them through 12+ years in our program, no matter what. We accomplish this by applying our program model, which outlines a theoretical background of how our organization connects the daily work of our friends. Our model identifies 5 strategies anchoring program services and outcomes. We experience success by teaching 9 core assets through intermediate outcomes of school success, pro-social development, improved health, making good choices, and plans and skills for the future. As our mentees grow and excel in these intermediate outcomes over this 12+ year time span, they experience the long-term goals and outcomes of high school graduation, avoiding the juvenile justice system, avoiding teen parenting, enrollment, employment, and enlistment. Next slide, please. ACEs directly touches our work, as our children must have 2 or more ACEs to enter in our program. Many of our mentees come into our program with high risk factors, child high risk factors, and environmental risk factors as high as 8 to 10 at such a young age. We experience and see ACEs in our work through life stressors and critical incidents. Life stressors are those environmental or individual circumstances with a negative impact on our daily functions. And then our critical incidents, which are incidents that occur in a youth's life that puts them at serious risk and harm. Next slide, please. Our goal is to support children with the highest risk factors and the lowest protective factors. We employ full-time salaried professional mentors who we call friends. We make long-term commitments and we stay with them no matter what. We continuously assess, evaluate to improve our work. Each dollar, as some of our outcomes, each dollar invested in our youth returns $7 to the community. 90% of our youth go on to enroll in post-secondary education, serve our country, or enter the workforce. 83% of our friends' youth earn a high school diploma or GED, while 50% of their parents did not have the necessary support to graduate high school. 93% of our friends' youth remain free from juvenile justice system, while 63% of the parents have been impacted by the criminal justice system, and 98% of our friends' youth wait to parent until after their teen years, while 85% of their parents started parenting during their teen years. Significant outcomes that we can look to for our success and how Friends of the Children is making an impact in the 25 locations that we currently serve. Next slide, please. So part of our program strength is in our two-generational approach that we call 2-Gen. That impacts changes across generations, not only for the youth, but for their families, by empowering them to move beyond poverty, foster care, the criminal justice involvement, and move toward health, well-being, and community. And some of the, many of the instances and examples that have already been provided through other panelists today speak to how we create healthy environments in our home, with our children, among our families, and within our communities. Next slide, please. And so I'll close with just a snapshot from our summer camp that was a couple of Saturdays ago, where a couple of kids jumped in the Snapshot with us to take a picture with the ice cream truck. I think that was their second or third visit back that day, and a fantastic time we had engaging our community and our families as a whole. And I'll close with this, because it was best said by our national team. Our work has ripple effects on their siblings, peers, neighborhoods, and their children to help break the cycle of generational poverty. Thank you today.
Thank you all so much. I'm going to ask our panelists to come off mute and back on video. We have a few minutes for Q&A. We had a lot of questions on resources, and we will post links on our website, and there's a lot of links contained in the slides also that are on our website. So I wanted to start, we had a lot of questions coming in about how to involve, educate parents on ACEs. You know, one question was, you know, how many parents know what ACEs are? And if any of our speakers could share some of their recommendations on effective prevention messaging without caregivers feeling blamed, especially, you know, if these are parents that experienced ACEs themselves.
May I ask actually that the grantees start out with that, because they do a lot of work on the ground that involves both the young people and then also the parents.
Perfect. Leon or Letitia?
Could
Sure.
you repeat that question? You went in and out, I'm sorry.
How to involve, educate parents on ACEs.
Yeah, definitely. I think some ways that we like to utilize is going back to meeting people where they are. You have to be involved, whether you have to go to the household, the schools, be out in the community, engaging with them, showing your face. And then once you build a rapport with them and they're comfortable with you, then you can slowly begin to inform them of ACEs and the impact that it has on our young folks and even adults. Also, I think you have to have a collaborative effort. It's not like necessarily one ideal or suggestions going to fit each and every individual. It takes community partners and so forth as a way of to engage them, is what we like to do and utilize. We found to be very effective.
I would just like to add one thing to that, and thank you, Leon. I think that is very thorough, is to also create opportunities for them to get involved. So meeting them where they are could include forming advisory boards so that they now know that their voices matter, and we're not creating programs or strategies or what outcomes that we think they should have necessarily without in isolation from what is actually happening in the home or the trauma that they may have experienced in life. So advisory boards, volunteer opportunities, inviting them into our community and into our direct work.
Okay, and Catherine, if I can add, and I'm in full agreement with what Letitia and Leon said, that, and this comes from about 45 years of working in communities, not the David Osher research you've been looking at in the last 20 years, and is that I think that it is also really enabling people to see that, as I said in my slide here, I didn't know it 30 years ago, that ACEs are not just destiny, even though we weren't talking about ACEs then. Because I think parents are often bombarded with information that they may need to know, but it's only negative information, and it can create self-fulfilling prophecies. But I think as well, the more you can help people understand the social context as well, that this is not just about you. This takes place within a setting, and what we want to do is work with you to enable you and us to be able to do things to really help heal and help your children survive and thrive, but also to deal with these things. It's not about you, but it is about your ability to heal and come together. And we're with you, as Leon and Letitia said.
And just
I
to
just wanted to
piggyback
add
on
to
that.
that.
Go ahead, Rodlescia.
Go ahead.
I was just going to say.
I just wanted to.
You
Go ahead, Phyllis. Go ahead. I'm quiet.
I was just going to say, and real quickly, that we really emphasize that everyone has a role to play in preventing ACEs, and that a big part of preventing ACEs is the entire community supporting families, and that by supporting families, we can do a lot to prevent ACEs. So it kind of like moves it away from the onus all being on the responsibility of the parents. Now, Rodlescia.
I was going to say something very similar. One of the things that we've been doing in Flint is educating the broader community about ACEs. such that service providers, people who work with youth and families, know what they are, and they can then pass that knowledge on to others. In addition, we've been working quite a bit with human service providers on designing programming to mitigate the negative aspects of ACEs. So working with the broader community and not necessarily focusing on individual families has really been our approach.
Yeah. If I can add one further thing, one of the ways you can enable and collaborate with families is also help them learn and understanding how they can, in their interaction with institutions like schools, what they should want to expect and what they should worry about, so that they just are not in a situation where they don't feel they can do something. And they can help define what's the level of scripting they need help with and so forth.
Well, thank you all so much. We are out of time, but want to thank our excellent panel of speakers for being with us and sharing all this valuable information, research, perspectives. And thank you to our audience for joining and being engaged. We will try to follow up on some of your questions and hope that you access the resources and a recording of this event. And your feedback is important to us. Please take a moment to complete a brief survey that will open on your screen after the event. And you can also access NIHCM's other resources, including a recent infographic on ACEs. So thank you all again so much for being with us today.